Hello and welcome to Pulse Check with Archer Nursing, where nursing comes to life. In this podcast, you give us 15 minutes of your day, and we'll take one complicated nursing topic and make it easy. Ready for nursing to be fun? I'm Morgan, and today we are tackling a huge topic, strokes. So as always, let's kick it off with our practice question. We've got a hard one today. A nurse is caring for an adult client who arrived to the ED with sudden right-sided arm weakness and slurred speech. The family reports the client was acting himself 90 minutes ago. A non-contrast head CT has been completed and it shows no hemorrhage. The provider states the client is a candidate for IV thrombolytic therapy, but their BP is 198 over 112. So which nursing action is the priority? We have A, administering IV labetalol to lower the BP, B, giving aspirin to prevent clot extension, C, keeping the client NPO, or D, initiating a heparin infusion. All right, that is a tricky one. Think about it, lock in what you think the right answer might be, and we'll circle back to it at the end of the episode. But first, we need to go on a deep dive because strokes are so important to understand. We'll start off with the brain. Now, the brain is basically a very high maintenance celebrity organ. It is only about 2% of your body weight, but it uses roughly a fifth of the oxygen. That is 20% of the oxygen and glucose at rest. And it doesn't store that fuel for later, which means that the brain lives minute to minute on a steady blood flow. And the only reason it can do that is because the cerebral arteries have this amazing system called auto-regulation. And what happens there, they auto-regulate. The vessels either constrict or dilate to keep perfusion stable, even when your systemic blood pressure changes. And it needs to do that since it needs that huge amount of oxygen and glucose, and it can't store any for later. Now, in a stroke, the brain is not getting that oxygen and glucose like it needs. And there are two big reasons that can happen. The two big buckets are ischemic or hemorrhagic. In an ischemic stroke, a vessel feeding part of the brain gets blocked, usually by a thrombus or a clot forming right there on an atherosclerotic plaque. Or it could be an embolus that traveled from somewhere else, like the heart in AFib. But for whatever reason, a vessel gets blocked, and downstream from that blockage, the oxygen delivery drops. And since the neurons in our brain don't have a backup generator, that area that is blocked from oxygen is going to start to die. If we don't restore blood flow, we get infarction, that surrounding area starts to die. And if we don't move fast to, get that oxygen, that fuel back to the brain, that brain tissue will not regain function. Now, our other bucket is hemorrhagic stroke, and this is a totally different villain. It is a different way that we can get that lack of oxygen to the brain. Instead of a blockage, you have a bleed. So ischemic stroke, blockage, hemorrhagic stroke, bleed. This is going to be a bleed either into the brain tissue itself or just around it. And the injury is from blood where it doesn't belong, plus that pressure. When we get that pressure, honestly, you can kind of think of the skull like a closed box. So when we add that blood from the bleed, it's putting more volume into that box and it can't expand. The cranium is a closed space, right? So the pressure inside, the intracranial pressure goes up, 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 and that pressure compresses the tissue, which then leads to decreased oxygen. Okay, so ultimately, stroke means brain's not getting the oxygen it needs. Ischemic stroke, it's due to a blockage. Hemorrhagic stroke, it's due to a bleed. Now, we emphasize these two buckets because which mechanism is happening is really important for treatment and nursing priorities because the body's going to respond differently to these two emergencies, even though they're both causing the brain to be starved of oxygen. So in an acute ischemic stroke where you have a blockage, it's natural for the body to respond with elevated blood pressure because basically the body's trying to just shove that blood around this roadblock of the clot. and get, more pressure so it can deliver that oxygen to the brain. And if we drop that blood pressure really aggressively, we can end up doing more harm than good. In a hemorrhagic stroke, we've got that blood flowing, that bleed. The body's not going to respond with an elevated BP, and we need to be really cautious of anything that could cause more bleeding. Okay. So, which type of stroke is happening is going to really inform our nursing priorities, which is a great time for us to walk through a clinical scenario. You are in the ED on a busy weekday afternoon, we'll say, and EMS rolls in with a 68-year-old. She was eating lunch and suddenly she just could not get her words out and dropped her fork. Luckily, she was eating with her colleagues. So they call 911. The paramedics arrive on scene. And because she was with people, we have a last known well, which basically is just the last time she was acting like herself. They say this was at 4:10, where her face drooped, her speech got garbled, her arm dropped. And you can see this is a very classic presentation of a stroke. The key component of that report was the last known well time, because we need to act very, very quickly when we suspect a stroke. You'll hear oftentimes people say time is tissue. Remember, the pathophysiology of what's going on is that this brain is being starved of oxygen. And the longer it's starved, the more ischemic and then necrotic the tissue gets. The tissue dies. It cannot come back. And that impairs function long term. So time really is tissue. And the faster we act, the more of the brain we can save. So we need to know the last time they were well to know what we can do. And we need to act fast. So, what is your first priority? We are going to follow our ABCs. This is a neuro emergency. So, airway, breathing, circulation, always what we have to address. Check their work of breathing, their oxygen saturation. One thing that I will call out for strokes is that their ability to protect the airway, reflexes like swallow and gag reflex can be diminished or absent. So you very well can have an airway issue. You need to make sure we have airway support and ventilatory assistance when necessary, especially if their level of consciousness goes down. In this case, she is still conscious. Level of consciousness has not gone down too much. She is aware and she has a patent airway and she is satting 98% on room air. So then we need to move on to managing this neuro emergency. One of the first things you're going to do, which might sound counterintuitive, is going and checking a blood glucose. All right. Why in the world is that? Because hypoglycemia can really mimic the symptoms of a stroke, and you don't want to miss a fixable cause of neuro symptoms. So, airway, breathing, circulation, grab that glucose and then get them to the CT scanner. We need to scan that brain and see what type of stroke is happening. We have those multiple buckets, ischemic and hemorrhagic. We need to see what's going on to know how to treat it appropriately. So in this case, they go and they have that CT, it comes back and they do not see an acute hemorrhage. That tells us we have an ischemic stroke going on, which can kind of shift the pathway of what's going to happen. But first, I want to talk about that bucket of hemorrhagic stroke. If a bleed was visualized on the CT and that is what we see is going on, we need to go to the OR so we can either coil or clip that bleed. Stopping the bleed is the only way we're resolving symptoms. In this case, we didn't have a bleed. That's not what needs to happen. We have an ischemic stroke, a blockage. How do we treat that? We need to unblock this vessel, okay? The first option we have here is antithrombolytic therapy. Antithrombolytics like Altplace are medications that are going to go into the vessel. They're going to find an existing clot and basically bust it up. You'll hear people call these drugs clot busters. Some contraindications are hypertension above 185/110 because that's going to increase the risk of hemorrhage. So you may see options like IV labetalol or nicardipine to get that BP below range. And an additional contraindication, if it has been over 4 hours since their last known well, they will not be a candidate for that IV thrombolytic therapy. So that's why time is tissue. We got to move really fast if we're going to use these clot busting drugs. So in this case, the client was a candidate for that alt place, that IV antithrombotic therapy. They were luckily with coworkers when they were eating. They got to the ambulance really quickly. We had a last known well of 210, and it was only just after 3 by the time they got to the ED. So we were able to get them to the CT scanner very quickly, rule out a hemorrhage, and administer that medication. So one of your nursing priorities is going to be going ahead and getting 2 large gaze IVs, drawing those labs while you get the IVs so we protect them from too many pokes, hopefully, and then administering that medication. Again, time is tissue. We got to act really quickly. Now, for this client, symptoms actually started to resolve rather quickly. That facial droop resolved. Her words became less garbled. That level of consciousness improved. This was caught so quickly. She was still certainly going to need long-term therapy and work on recovering. We put in for a swallow eval to make sure that all of those muscles were working because clients after a stroke can be at very high risk for aspiration. But she responded very, very well to that alt place. That is really the best case scenario. She had a clot. It blocked that oxygen flow. We got to her really, really fast. We relieved that clot. Oxygen got back to that brain and did not leave long-term damage. If it had stayed for longer, maybe she'd been eating lunch by herself and no one had noticed, it took her longer to get over to the ED, that clot could have starved the brain of oxygen for longer, and we might not have seen such a swift recovery. Not everyone responds to that antithrombolytic therapy as well. So I do want to talk about the next step in intervention is something called a thrombectomy, where we do go to the OR and we have that mechanical removal of the clot. Ultimately, when we think about our 2 buckets of stroke, if we have a clot, we need to get rid of the clot. If we have a bleed, we need to stop the bleed. So for hemorrhagic stroke, OR, we're going to clip or coil. For ischemic stroke, we're going to try that alt place if they're a candidate, or a mechanical thrombectomy if perhaps they are not. But ultimately, the goal is we are restoring blood flow and therefore oxygen delivery to the brain. Which brings us right back to our practice question where we started the episode. A nurse is caring for an adult client who arrived to the ED with sudden right arm weakness and slurred speech. Last known well was 90 minutes ago, and a non contrast head CT has been completed and shows no signs of hemorrhage. The provider stated the client is a candidate for IV thrombolytic therapy and the BP is 198 over 112. What's your priority action? We had A, giving IV labetalol as prescribed, B, giving aspirin, C, keeping them NPO, or D, initiating a heparin infusion. Think it through, lock in your answer, say it out loud with me. What do we do first? You might have said B, giving aspirin. That does kind of sound helpful, but antiplatelet timing matters around potentially giving thrombolytics. And we know they're potentially a candidate for that antithrombolytic therapy. The immediate barrier, the thing this question wants you to call out, is that this client cannot safely receive that alt place, that thrombolytic, until their BP is controlled. Remember, when we have a BP in excess of 185 over 110, the risk of hemorrhage increases. So we need to get that down into the recommended range so that they can get that clot busting drug and we can restore perfusion. So that's why I'm going with A, giving that IV labetalol to lower the blood pressure to the recommended range. C, do we need to keep them NPO and do a swallow eval? Yeah, absolutely important, but not the priority. Time is tissue. This is a circulation problem with that blood not being able to get to the brain. So we need to address that barrier of the hypertension and make sure they get that medication. That is our priority. And D, initiating heparin, not a first line acute treatment for ischemic strokes. It would actually increase their bleeding risk. So the big takeaway is this. When you hear stroke, think Oxygen is not getting to the brain. It can either be in the bucket of an ischemic stroke where we have a clot or a hemorrhagic stroke where we have a bleed. Either way, your nursing intervention is all about getting that oxygen back to the brain. And to do that, we have to prioritize figuring out what type of stroke is happening. So get that client to the CT scanner and move quickly because time is tissue. All right, future nurses, that is a wrap. If you found this pod helpful, I'd love to continue supporting your nursing journey through nursing school, the NCLEX, continuing ed, and beyond. Archer Nursing has you covered with on-demand video lectures, high-yield question banks, live case study reviews, and so much more. We want to help you master tough concepts and make it fun. So join us over at archerreview.com. Follow us on socials at Archer Nursing for more free nursing tips and study resources. Thanks for tuning in to Pulse Check with Archer Nursing. I'm Dr. Morgan Taylor, and I'll see you back next time.